Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, thank you for joining us for today's webinar, Operational Best Practices for CMS's Home Health RAP Changes. My name is Molly Casey, and I'm on the marketing team at Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Joining us today are Tammy Ross and David Huber. Tammy is Senior Vice President of Professional Services at Axxess. She leads a team of professionals whose goal it is to provide education as well as practical operational solutions to home health, hospice, and home care organizations. Tammy has 30 years of home health experience and has served as a senior executive of a large national home health agency. David Huber is the Vice President of Revenue Cycle Management at Axxess. He leads the company's billing, electronic data interchange, and payer management service teams. To date, David's team has processed more than $14 billion in Medicare and managed care claims. Prior to joining Axxess, David had served in a variety of roles in the healthcare industry, providing operational and financial expertise for over 30 years. Thank you so much for joining us both today. And David, I'll hand it over to you.
Thank you, Molly, and welcome. We'll hopefully get through and help you understand what's going to happen with the RAPs as we get closer and closer to 2021. So hopefully, as we look at this, there's been some confusion, and it's been, we're still getting some information from CMS, but just clarity of how these things are going to happen as we move into these changes. These changes were outlined when PGDM came into effect last year, but some of the details were left out, and so we're going to communicate what we know right now, and there's still a few things that are a little bit undecided at this point in time operationally, but hopefully we'll let you know everything that we can at this point, and if we have any changes, I'm sure we'll have another conversation about this. So a couple of the objectives, the participants will review the background of 2021 regulatory changes and understand how this can impact their bottom line. Then also understanding how and reviewing the technology that can ensure a successful transition into 2021. And then also we're going to explore how to tighten up operational processes and hopefully prevent some of those RAP penalties that we'll be discussing here shortly.
All right, David, it doesn't seem like it was that long ago when we were here discussing PGDM and RAP changes, and we did a bit of a two-step where we had to kind of get on the same page about what operations would do and what financials would do. And we're back at that same place again, and I'm confused again. So can we kind of just start with what's happened with the RAP and revenue cycle management and kind of that evolution?
Absolutely, Tammy. So let's take a few steps back and before we go forward, and let's talk about setting the stage and where we were over a year ago with PPS. So in PPS, the RAP qualified or established two different things. Number one, it established the episode in the common working file, so it let CMS know that a member was under home health care. It also had billing periods, so there was some financial impact on it, so reimbursement, which matched the 60-day episode. There was a RAP at the start of that episode, and that initial split was 60-40, so 60% of the payment was paid at the RAP and 40% at the final during the very initial episode. Every subsequent episode after that was a 50-50 split. 50% of the payment came at the RAP and 50% at the final. The RAP submission requirements were that the OASIS was completed and ready to be submitted. Physician orders were received, a plan of care was sent out to the provider, and the first visit was completed. Now, moving into PGDM as of January this year, we had a few changes that occurred and it really affected a lot of things, but in addition to that, also the RAP. So the RAP is still established in the home health episode in the common working file, but there's a change in how the reimbursement works. So there's still a 60-day episode of care, but now the payment mechanism is split into two 30-day periods of care. Each period of care would have a RAP and a final submitted for each one of them. All periods of care are split a 20% and 80% split payment. So there's not an initial and there's not a final, and it went from the 60-40, 50-50 to everything being 20% and 80%. Also, the primary diagnosis can actually change during these periods of care. So the second period of care could have a different primary diagnosis. And if you remember correctly, that primary diagnosis is what's controlling the clinical grouping, which also controls the payment amount. And then the RAP submissions requirement are basically the same. OAS is completed, ready to be submitted, physician orders received, plan of care sent, and then first visit completed. But the thing that you already have in the two periods of care is the OASIS physician order and plan of care are already established during the first period of care. So really in the second period of care, the only thing that really needed to be done was the first visit completed. Does that help a little bit, Tammy?
It does help a little, and quite honestly, when all of this first came out with PDGM, you know, I was confused as well as a lot of other operators. We never thought we could get past that 20-80 split, and we did, but I'm still a bit confused about what 2021 is going to mean for me. Is there a place that I can go for resources, and can you just tell me more about that evolution of the RAP in 2021?
Absolutely. So let's look at that in 2021 and a little bit beyond that, because there's still some more changes coming originating from PDGM. So first thing is that the RAP is no longer used for two things. You know, it had been used for the establishment of the period of care or the services for the home health member. So it is now only established in that period of care, period. There is no payment associated with it. So there's no split payments. It's 0 and 100. That's the split. And then also they're implementing a non-timely submission penalty, which means that the RAP has to be accepted, not just submitted, but accepted in the common working file to qualify. That has to happen 5 days from the start of care on the initial period, and then 5 days from the start of the second period of care. So usually that after the 30th day of that period of care, the next day, the 31st day of the episode would be the start of that second period of care. The penalty is going to be 1/30th reduction in each day late. So basically the payment that you had is divided by the number of days in that period, and for every day that you're late, they take a day away from you. And then kind of in line with that, if it is a Lupus situation, then no payment will be paid on a Lupus visit prior to the RAP submission.
Hey, David, I have a question. You said
Sure.
accept. So how long is it from the time I file generally until it gets accepted for payment?
Well, usually it's a little bit dependent on the MAC and the situation that's going there, but normally it's within a day. But you know, when you're starting talking about 5-day periods and when it's accepted, you know, there are times when MACs have shut-off times, and so you have to be careful of when that submission occurs. If it's at 3 o'clock on a Friday afternoon, it's very possible that won't get submitted until Monday. Well, that's 3 days of time, so there could be an issue that could affect your timely filing of that RAP. So it's very careful, and we have to be very mindful of that. And in fact, what we should be doing is trying to get those RAPs submitted within that 3 or 4 day period and not get to that 5. And actually, it will be 5 or 6 day, because day 1 that you do the start of care is considered day 0. So 5 days from that, you can submit it on the 6th day and still qualify if it gets accepted. but that's not going to be that's going to probably be a rare case that you can submit it on that.
I can see I'm going to have to make some operational changes, so I'm taking some notes here because I'm sure you're going to drill me on it in a bit.
I will, Tammy. And also, additionally, we're talking about the and beyond. January 1st, 2022, the RAP will actually be replaced with a notice of admission. So will no longer be called a RAP. It will actually be what it's intended to do is actually send a notice to to Medicare and the Common Working File that a member has been admitted to home health care for the period. So that's a little bit different, but it's very much in line with what hospice is doing with their NOE or notice of election. So it's a very similar situation that's going to happen with home health. So Tammy, let's look at what kind of that does to our revenue cycle management. And I actually did a little graph to show, since this is all happening within this, basically a 2-year period, we're having all of these different kind of changes in our cash flow. So if you look at the very back, that's the PPS kind of cash flow where we got a lot of the, like I said, the 60-40 split. So we had 60% of our money on the front end and then got the 40 after the end of care. And then you had PDGM where you went down to 20% and got 80% on the final. Now it's going to be nothing until the very end of the episode. So a very significant change in cash flow and how how your business and operations is been able to carry that deficit in cash flow. Again, it appears that PDGM, the revenue is not being affected as long as you don't have the penalties, but the cash flow is a very big consideration to figure out how much money you're spending and what time frame you're spending that money. Revenue recognition becomes another critical issue. Making sure that you understand that you recognize revenue accordingly. Again, talking about the cash flow and having expenses over the term of the period of care and understanding how much revenue that you will be receiving for that. What you don't want to get into a situation is realize that you've lost money at the very end and don't have any ability to change anything during that period. Avoiding penalties and revenue reductions. Again, managing your revenue is great when you know what the revenue is, but when if you start having penalties, then again you're changing the end of the revenue model, and that becomes a different cash flow consideration. So and just realize that this penalty can go to zero. So if you're late a month to submitting the RAP, then you actually will not get paid for that period of care. So very significant and important thing to be able to manage. And then also looking at the submission requirements, they are reduced. So that's actually a positive thing. So we're going to talk about it in just a minute, but that takes a little burden off of the agencies. Also, no more rejected RAPs and resubmissions. So last year, Tammy, we were out talking about how the duplication of RAPs and finals is going to put more effort on your billing team and things. You're going to have double everything. You're going to have double the submissions, double the postings. Now we're going back to not having that again. Also, like I said, the reduced posting. So you will have some changes in the expenses and the effort that you're doing to actually submit RAPs and finals.
I can see, though, you're going to be heavily focused on us getting our finals dropped pretty quickly at the end of that billing period, because all that cash flow, I mean, this is just a really good visual. All that cash flow is at the back end now.
Yeah, it's very, very key to understand what you have and how fast you can get it. So that's definitely going to be a critical point, is that our revenue doesn't change and we don't have those penalties, and that we get that money as soon as possible after that final.
I'm writing my notes. I'm going to have to do some improvement for orders management for sure.
So here's another chart, and it kind of shows that penalty. And I kind of wanted you to see this, is that we have a small window, that 5 days, so from 0 to actually the 6th day. But as soon as that day hits and we're late, we're going to lose 5 days. So about 17%, 5/30ths of that episodic payment goes away as soon as we're late. And then every day after that, you can see the slope as it goes all the way down to nothing. So that is a key component. As as it evolves, if we're 10 days late, then I have basically 1/3 less revenue that I actually can deal with. So that changes my cash flow. So monitoring and managing that is going to be key as we move into 2021. And then also
Hey,
the low.
David,
Yes, Tammy.
just so you know, 12% of agency, oh, sorry, not 12% of agencies, but the national average for filing a RAP is 12 days. So and I'm better than that. You've got me down to about 6 days now, but 12 days. So that would mean if they're not filing till that 12th day, then that's money lost, right? They're going to lose all those days before the 12th day, correct?
Yes, then that is one of the biggest changes, and I know we've been working on it this year and a little bit at the end of 2019, getting that down, and that's why it was so critical, is because we are now not just talking about delayed cash, we're not just talking about resubmitting when we get a chance to, or refiling whenever we want to, we're talking about loss of revenue. So it is definitely going to be critical now to get underneath that 5 day, and really we should be sitting at 3.
Yeah, that makes sense. And I feel sorry for those agencies that are at the national average of 12 days for filing a RAP.
Now, the good thing is that the requirements are less, so we're going to be able to change a little bit of that. So hopefully that changes your average and brings it back into that range, what we're expecting, because you have the reduction, you don't have as many things that need to be prepared for the RAP.
Got it. Yeah. At least we have a positive on one side.
Absolutely. So, and just a reminder, those LUPAs, if it does become a LUPA and we're not going to get paid on that visit. So, again, the LUPAs break the episodic payment and change back to a per visit payment. So anything behind the RAP will not get paid. So Tammy, it's kind of very similar to like a managed care when you have an authorized services. That RAP kind of authorizes you for services. So anything before that basically doesn't get paid.
That's a great way to look at it, actually, is not having authorization, because basically you don't if you don't file in time. That's a great way. Great analogy.
Absolutely. So here's where I'll get to flip it back to you, Tammy. What operational items and actions can you take understanding that these changes are coming around? So just like we were talking about, how are you going to monitor the RAP countdown? How are you going to make sure that you're meeting the guidelines for submitting a RAP? How are we going to manage those LUPAs to make sure that we're not missing those? Also, what kind of adjustments should we think about changing and reporting? I mean, I know that some of that information you're going to need different information from our group. And then also, we need to collectively talk about what do we need to do with technology to help the operations so that they can identify these things clearly and quickly.
Okay, let's start with that then. We'll start with operational items. I took notes as you were talking. One thing I think I really have to track is that visibility for late and missed visits or incomplete visits. So what I have to make sure that's happening is that the start of care is actually completed in a timely manner. And there's no more, start of cares that staff don't turn in the visit paperwork or complete electronically until 3 days later. That has to be completed in that office in 24 hours. The other thing I thought about is that start of care when you have a secondary discipline. Let's say a nurse is going out, but therapy is also ordered. It's been really important for me under PDGM to have that therapist take a look at that patient because of functional scoring. And I still think that has to be a part of my operations going forward in 2021. However, now, instead of waiting a day or two to get that therapist in, I'm going to need to get them in that very first day, that same day as that start of care, because just like you said, I don't have the time to wait. I need them to collaborate within that first 24 hours. Go ahead and get that done, even though we're not, it's not OASIS driven, but I want that information up front, and I want to make sure that that nurse can complete her first billable visit, that skilled note, within that 24-hour time frame. I think having to maximize workflow efficiencies, this is where we talk a little bit about technology, and I've got some notes later for some reporting I'm going to need, but maximizing clinical intelligence. The burden is really going to be on those nurses and therapists in the field. So anything we could do to speed up their productivity and their ability to document that billable visit quickly is going to help us out tremendously on the back end. Something that you had mentioned was that verbal order. We have to have that now. It sounds like the requirements have really went down. We don't have to have that OASIS completed, but we do have to have documentation of that verbal order for that start of care. So I really have to look at how we're doing that. I know software systems that actually put that directly on the plan of care. And, that's what we have to have. Like with Axxess, it's directly on the plan of care. So I have to make sure that that verbal order, because I think that could be a compliance issue in 2021. Anytime I've seen changes like this, you always look for where it could be a potential risk, and that could be one. Quality, QI, CPQI, I think it's going to be really important that we get that through QI quickly to make sure that visit is billable. But then again, I think that's where technology can help us out, and our vendor, and especially Axxess, does this. They make sure that billable visit is completed on start of care before we can close that out. So that gives me the assurance that, yeah, we've got this done and we've got it done timely, and we've made sure that that visit is billable. And there's a lot of compliance things around the billable visit. Just doing an OASIS isn't a billable visit. So I pulled this up as you were talking about the WRAP requirements, and just looking at exactly what CMS says. It says a physician's written or verbal order, and we know the referral is not the physician's written order, especially the referral that says access and admit to home care. That's not going to cut it. So I've got to make sure that we narrow that down. That's required, and that initial visit within the first 60-day certification period has been made, which we certainly want that to be on start of care. There's no more of those times. Remember back in the old days where you were using physical therapy as contractors, and you would send your nurse in to open up that case, and that was non-billable, and then your PT would come in. We can't do that anymore. And it being like similar to hospice, because we have that line of vision, makes complete sense, that it has to be accepted by that 5th calendar day. Now, you really clarified something for me, that we start counting at day 0, but I think for my mind, operationally, I'm going to still count that as day 1, because it's still got to be accepted by the MAC. So that kind of builds me in a little bit of a cush there. And then that second billing period WRAP can be sent at the beginning of a certification period. David, this is where I think it's going to help your team. And correct me if I'm wrong, but that way we can do both WRAPs at the same time, right? We don't have to wait until that second WRAP.
No, that is absolutely correct. And we can get both of them out. And, even though, because we're broken up into 2 30-day periods of care, if something happens and changes, we've talked about the changes with the primary diagnosis and actually changing the grouper. If that happens, we actually can, we have that time to make that change, make that adjustment, and resubmit the WRAP, even, up to that, like I said, that 5th or 6th day in the 30-day period. So, but it saves us a lot of time and effort by just submitting it all at one time. And then if we have the change, which is not the ordinary operational thing, then we'll deal with that instead of dealing with having 100% having to submit twice.
Yeah, I like that. I think that's going to be best practice. And like you said, it's going to take down some of the work that we've been doing by submitting 2 wraps and 2 finals. I drew out something for the lupus. I think it's on our next slide because I have to see things visually. So when you were talking about lupus, there could be a very good chance you can lose almost all your money on a lupa, right? If you don't get it out. Every visit, nothing counts as a lupa. So I thought of some scenarios that come to mind where you actually you perform a start of care and then you do quite a few visits, but you don't meet that LUPA threshold. So in PDGM, LUPA thresholds varies from 2 to 6. Let's say you had a 6-visit LUPA threshold and you wasn't really paying attention to that, and you didn't get your wrap out timely. So if I'm looking at these 2020 LUPA rates correctly, in this example that we show on the left-hand side of the screen, I would do 1, 2, 3, 4 or 5 visits and only get paid $67.78. Does that look right, David?
Absolutely, and that's you know, again, because anything before that submission and acceptance into the common working file for the wrap doesn't count. So again, that the X that we have on the calendar is showing when the wrap should have been submitted, and it doesn't happen till the last day. So that first week of all those services goes away. And I think it's really important for you showing that the fact that that hospital readmission or going back into the hospital can affect the rest of your episodes. So you know, that's one of those unforeseen, unplanned LUPAs, which we talked about previously, and it's going to affect our reimbursement tremendously if we're not on top of the wrap. Another thing I'll also mention is, you know, we've seen that a lot of our LUPAs happen in the second billing period because the LUPA thresholds tend to be much shorter. And so, I mean, it really can impact how we do it if we're not careful about submission of that wrap and getting it in timely. Again, because like I said, a hospitalization is something that we may or may not have planned on.
Yeah, and I think again, technology here is going to play a key role. Being able to see that in the schedule and where it identifies my LUPA thresholds and it identifies my potential LUPA impact like we have in Axxess is huge for us. That's going to help us prevent this. I'm just going to have to make sure that our folks that are watching the schedules, our director of clinical nurses and so forth, really keep their eye on this.
Absolutely. So let's talk about some of those technology considerations. I know we've had some conversations about what it's going to take, and you know, you've said a few things. You know, the first thing that comes, you know, of course, first in mind is a wrap aging tool. And I think it's great for it to have that visual like you're talking about, to make sure that we can see where these wraps are, what the time frame is, when it's going to get critical to be able to deal with that. Like I said, we still have an acceptance, not just a submission. So it's not an immediate thing. So we have to be prepared and have something that we can monitor. And I've got something after this slide to show you one of the things that we're seeing in Axxess that will help identify that for us. Also, enhanced payer setup. So we definitely want to make sure, because this basically comes as a different way of reimbursement methodology. You know, we've seen over PDGM, you know, we have CMS following PDGM to the letter, but then we also have some of the Medicare Advantage programs sort of following PDGM, and this is another kind of nuance that we, you know, may or may not see fully transitioned at the first of the year. So we're definitely going to have an enhanced payer setup so that we can deal with all these multiple different methods of payment. Also, reporting enhancements, you know, we talked about that. One of the big things on my section is monitoring that penalty and making sure that I understand how much is happening on that penalty. Again, I'm going to need to be able to provide you some information if it gets, I mean, I'm sure that we'll take us a moment to kind of get used to the changes, and if I have the right reporting, I can monitor how much that it's affecting us. And then, moving forward, if it ever pops back up or we're having another problem, if we open up a new agency or have something like that, this may be something that we monitor on the front end to make sure that we've got it into that, a real tight process operationally. And then business intelligence, we've had some discussions about this, understanding and being able to flexibly move reporting around and see different components of it and measure from 2 different points of data, some clinical, some financial, some operational, gives us a lot of insight and a lot of ways to measure and perfect the processes that are out there.
Yeah, David, that reporting as you were talking, I think I would really like to see any of my penalties adjusted for my revenue, just kind of like we used to do with Lupus and therapy up codes and down codes on the end of month reports. If there's a way that we can see those penalties the same way, that's going to give me good visibility of where I have to make changes.
Absolutely. So real quick, here's a quick look at the RAP aging. This is in the billing center for Axxess. And, we used to have an aging just to show you how old they were. Now it's more of a countdown. You can see the green from 0 to 2 days. It gets yellow from 3 to 4 days. And then if it's 5+, it is in the red. And again, the longer that it's in the red, the more money that it is bleeding. So watching this monitor and have it go through allows my billing team to really keep an eye on it. And of course, I'm sure you're going to get communications if we get into the yellow, into the red from the team to hurry up and get everything ready so they can release those wraps so we don't have any of those reductions. Also, just a quick reminder is when we do the double submission of the wraps with first and second wrap, this will actually count down to when that wrap's due. So it will actually show a negative. So if we have any changes, and I know that we still like to do those 30-day, on the 25th day, we have a 30-day meeting about any changes that might happen. So we'll capture any changes for that next 30-day period. This may be something that we can monitor to make sure that anything that's there that needs to be changed can be changed.
Oh, that's a great idea, like for the change of focus, right? For the change in diagnosis, I could use this.
Absolutely.
Hey, David, will I be able to drill down to the patient level when I look at the things on red? So if I pulled that up every day, could I drill that down and actually see what patients?
Actually, yeah, the aging buckets are actually clickable, and as soon as you click on it, it will highlight just the ones that are in that bucket, so you can focus on any one of those buckets. Straight from there, and you can kind of see behind our excerpt, you can see that the patient name is in blue, which means that you can drill straight down into that patient.
Oh, that's going to be great. That's going to be a huge tool for us to use. Thanks, David.
So
I have some questions for you too that I pulled up. So if you could explain it to me in easier terms. I think everybody would appreciate some of these answers. So we talked a little bit about that, but sequential billing in 2021, what's going to happen with that? Do we have to have it?
So no, sequential billing, even though home health is moving more similar to a reimbursement method, or at least timing like hospice, it is not required sequential billing like hospice is. So wraps for the first and second 30-day billing periods can be sent at the very beginning of the episode. So it doesn't require wrap, final. So that is something that's good. And the excerpt from CMS is down below. It says home health agencies will be allowed to submit both the wrap for the 30-day period of care and the wrap for the second 30-day period of care. And you got to remember, this is still for a 60-day certification. The episode has never changed. It's just the payment method. And they can be done at the same time. And really, like we talked about, it's to really reduce that administrative burden that they kind of put back onto us with PGDM this past year. Now they're kind of reducing it away from us.
Okay. All right, a couple of more questions. Will wraps only require a verbal order and first billable visit for the episode to be completed prior to submission? think you kind of answered that for us.
We did, and just to reiterate that again, that is part of this reduction. That's why some of these wraps you'll be able to do a lot quicker. You know, we said that you were sitting at the 7-day range, 8-day range right now. You know,
Yes.
Being able to reduce some of those requirements, you know, just by having a verbal order. And just a reminder, because I know this is something that we've talked about, you know, just the verbal order, we still have to get the order in place, and every one of those requirements are still there. It's just not required for the wrap submission anymore. And so since and then really the big change is because there's no payment associated with the wrap, you can just do the physician when you have the written or verbal order, and then you also have to have the initial visit within the 60-day certification period. So again, that becomes a portion, and we've talked about this with PDGM around scheduling anyway. That shouldn't really affect anything, and we should be getting that done as quick as possible.
Okay. That makes sense. How will the HIPS code be determined on the wrap if the OASIS isn't required to be complete? How are we going to get a HIPS code?
Well, and we got to remember when we moved into PDGM, basically CMS said we'll take care of calculating the HIPS. Even though we have been submitting it for claims, what we submit as a HIPS code has never been used for the PDGM determination. So it's the information that's in the common working file, it's the information in the OASIS. You know, we talked about the levels, the therapy levels, and then also what in the diagnosis. Those are the things that really have been controlling the HIPS code. So the HIPS code reported in the wrap is no longer required to match the HIPS code calculated on the assessment. Any valid HIPS code can be reported on the wrap. The one main thing is that the HIPS code on the wrap and the final have to match. So other than that requirement, what's on the OASIS and what's actually getting reimbursed is really inside, you know, the CMS inside their system.
The only reason we would really want to try to keep it as accurate as possible is so we could forecast the revenue, right?
Yeah, and that's really what we're talking about. So there's going to be a HIPS code on the wrap. There's going to be a HIPS code generated from your OASIS, which is going to be an estimate of payment. And then there's a HIPS code on the final. And we know the HIPS code on the final and the wrap have to match for purposes to ensure a wrap was submitted for this final. But the OASIS is really going to, and what's generated after that OASIS is going to control the financial reporting. That's going to be your estimate to make sure that you were getting reimbursed what you thought you were getting reimbursed or needed to be reimbursed for that. The big thing on that is that you're no longer having to wait for that OASIS to get completed, so you can submit that wrap before that happens.
Okay, now I get it. That makes sense. Are there any changes to the automatic wrap cancellation policy?
Well, the great thing about this is it's no longer subject to auto cancellation. Again, because there is no payment to recoup, that does not matter, and there is no auto cancellation. The big change to this is, again, we used to be able to have an auto cancellation and just resubmit it, and there was no problem with the revenue. It was just a delay in time and cash flow. Now, you know, again, we don't have that problem, but we now have the problem of reduction of revenue from the penalty. So a little bit of switch of focus, but that at least takes this one thing off of our plate.
Great. And what are the changes to the first billable visit requirement? Are there any changes?
So the first billable visit for the episode actually will require satisfy the requirement for both the first and second 30-day billing wrap. So the initial visit within a 60-day period has been made, and the individual has admitted to home health care. So that really becomes the process or the actual event that creates that episode of care. You got to remember that, you know, the episode of care has not changed. It's 60 days. So the notice of that is actually the what's going to qualify as the first billable visit and the member becoming underneath an episode of care. On the wrap on the next visit, so the start of the second 30-day period is when that starts. So that becomes, that's again, when we're submitting these wraps together, that's why it's so much simpler. The requirement's just not there.
Hey, David, something that you had mentioned about the advanced payer setup. So do you anticipate any of the Medicare Advantage plans maybe still requiring that second billable visit on the 30 days? I guess they could, right? They could do whatever they wanted.
They can do whatever they want to, and that's kind of what I alluded to. What we've seen with PDGM is a little bit of we like PDGM and we think it works really well, but they don't have all the technical specifications there. We've had situations where different groupers were being used, or maybe they were using last year's versus this year. We've had some stops because of different information coming from the different interpretation of the CMS rules from what CMS says and what the Medicare Advantage program says. So there's some nuances, and sometimes it took a little while for some of these payers to get used to it. You know, at first, I don't think that they were kind of like the rest of us in the industry. It took us a while to really understand what PDGM and how it actually functionally worked. So we definitely have to have flexibility in our payer setup to deal with ones that aren't quite PDGM and again, not quite ready for this wrap change.
Got it. And what dates are going to be reported on the home health service line on that wrap submission?
So like we talked about, the first billable visit on the first period of care is what's going to be reported. That's the date. And then on the second billing period, it's going to be the first day of the billing period. So like I said, that's really what controls it. The first billing period kind of starts that episode of care, which is what the wrap's being used for right now, is just to notify that there's an episode of care happening on this member. And then as soon as the second billing period starts, that's the date that the second billing period starts. So that's what's going to show up on the plan.
But that's pretty easy to understand that one. And usually that's going to be my start of care date for that first wrap.
Absolutely.
And diagnosis codes, are there certain diagnosis codes that need to be reported on the wrap?
So you know, I know that's your area of expertise, but as far as mine, the only thing that needs to be reported is the principal diagnosis. And right now, again, because it's not associated with payment, it's one of those things. I think it's more of a processing component because wraps require that as a data field, but it's really not used for anything. The only thing that the diagnosis is going to affect is when you file the final, and hopefully you have all the diagnoses that are pertinent, not only the primary, but in case you have some secondary diagnosis, or because it could affect the reimbursement in which HIPS or the comorbidity code that comes from those. But as far as the wrap is concerned, only the principal diagnosis is required.
Which really makes it a whole lot easier for us. It kind of unlocks our hands some with trying to get all of that set up front so that OASIS matches the actual claim, and that, you know, we try to get all that done quickly with pre-coding. Really, it's coming at the back end, and like you said, if we don't have it by 60 days from then, or even 30 days from then I've got some huge operational issues. So I think this is going to make it much easier. Oh, exceptions. Okay, so what if there's a disaster? We've been having a lot of hurricanes going through the South and even through Texas. Exceptions to that late submission penalties, so maybe I won't be penalized, like for disasters and so forth. Does CMS allow for that?
Yeah, absolutely. They're going to introduce a KX modifier. You know, it's something that modifiers are used in a lot of healthcare billing, but they're going to allow this to be used under the submission of a wrap. And basically, the one thing that is important here is that it's a request. That KX modifier is telling CMS that they are requesting an exception to the late penalty. And again, that exception is going to be evaluated by CMS. And, you know, again, like you mentioned, having, you know, whether it's the fires in the west or the hurricanes in the south or snowstorms in the north, you know, whatever it is that may be affecting the ability for an agency to do that, they're going to verify that information. And one thing that comes that I, you know, as an example of a place where this may be used is if you have incorrect eligibility reported to you by the Common Working File or CMS. And that happens sometimes when you have a Medicare Advantage member that decides to go back to original Medicare, and the update does not hit the Common Working File in time while you're letting them, bringing them on to home health. And so that would be a perfect example of why you possibly might be late, because originally you wouldn't have filed with Medicare because you thought it was a Medicare Advantage. But if there was actually a retro eligibility change, you can actually come back, refile that, be, you know, on the 6th or 7th day, put that KX modifier, and that should qualify because they should be able to check their system to tell when eligibility was updated.
Hey, David, but that would have to be a mistake on their end, right? What if it was a mistake on my end? I just didn't catch it because I'm not running my, you know, Medicare eligibility. Would they give me an allowance that way too, or is it only if it's a mistake on their end?
Well, let's look at the fourth situations that this comes into place. You talked about the fire, floods, earthquakes, or unusual events. And then I just talked about an event that produces a data filing problem due to a CMS or MAC system issue. Also, a newly Medicare certified home health agency that's notified that certification after the Medicare certification date, so that there's a little timing difference between when they actually can bill versus when their certification happened. And then also if there's any other circumstances, you know, that's kind of up to their leeway. But I promise you, if it's your mistake, it's not going to qualify. It's got to be something that's out of the agency's control, or that it was a problem with a CMS system.
Yeah, that makes sense. I doubt they'll let it be because I forgot to check my eligibility or make the changes when I should have.
Yeah, unfortunately, they're not going to take that as an excuse.
All right, so what do we do next? So I think for me, staff education is going to be huge. Making sure that I also educate my referral sources is going to be vitally important, that I start getting back those orders more timely. You know, there's several occasions that, you know, we can go over 30 days sometimes for orders, and I know financially you're not going to allow that to happen on the back end. So I've got to work on that. I've got to look at some ways to streamline my processes, look at my resource management, my scheduling system, which luckily, you know, I use Axxess, so that's not going to be a problem. But also looking at my orders management within Axxess and making sure that we're working that every day diligently and getting ahead of the game before January 1st starts. Technology-wise, no pay wraps, definitely. You got to have that in your technology system. We do here at Axxess, that wrap aging, penalty adjustments. How are we going to account for that? And David, I know you're working on that now, as well as enhanced workflow. Anything we can do to make it more efficient. And then certainly, you alluded to this, unbundling the OASIS from the wrap. You don't have to have that OASIS complete anymore. So that doesn't need to be tied to that wrap. And then for change management, looking at our business intelligence for ideas to where we need to focus change management, making sure we start setting those expectations. And, you know, I think sometimes we're held hostage to expectations, and we allow nurses and therapists as well to say, you know, kind of hold us hostage because we feel like we don't have another choice, and that, you know, there's such a staffing crunch. But I think if we start setting those expectations now, and we are, you know, just diligently keep those expectations with consequences for not meeting them. And then I think to have full visibility with where we're at in the process and how close we are to meeting those benchmarks. And I'm sure you and I are probably going to start weekly meetings again, so we can start making sure I get to those areas before January 1st.
Absolutely. So let's just talk about, quick summary of what we're talking about. So remember, there's going to be an elimination of the split percentage payment. So the RAP will not affect payments whatsoever. There's going to be an implementation of a penalty for delayed submission of RAPs. Revenue reduction for that penalty is going to be 1/30th of the episodic payment per day. And so, and it will go all the way down to 0. So reduce RAP submission requirements, that's a positive, that's a help, that helps us maybe get to that last little effort to get these underneath that 5-day window. And then all reimbursements paid on final claim. So that's going to put a lot of impetus on getting the finals done timely, all the information ready to go so that I can submit those claims, because now I've been holding cash flow and having expenses for the effort that I'm doing with no revenue for more than 30 days already. So the tighter that I can get that, the better off that I am for a cash flow purposes. And then operational changes should occur now to prepare for 2021, just like we did with PDGM. Shouldn't start on January 1st. We should start now to try to get this. A lot of these things are just good practices anyway.
Thank you, David.
Thank you, Tammy. Look forward to 2021 with you.
Thank you, David and Tammy, both. We really, really appreciate all the great information you provided today to help organizations prepare for the upcoming changes. Just wanted to mention, if you haven't already checked out the new Axxess user community, I encourage you to visit it at community.axxess.com. It's a great place to share information, ask a question, and connect with other Axxess users. Thank you all for joining us today, and we look forward to seeing you on another webinar soon.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.